All right, we're back. Part 3, Chapter 16, Airway Management. Let's get started. So we're jumping off into endotracheal intubation. So endotracheal intubation, it involves passing an ET tube through that glottic opening that we've already seen, that entrance to the trachea. The tube's sealed with an inflatable cuff against the tracheal wall to secure the airway and prevent aspiration. So within this, we have a couple of different types of intubation. We have orotracheal and nasotracheal. So orotracheal, inserted into the trachea through the mouth, the most common method for securing an airway in emergencies. And then nasotracheal, the tube is inserted into the trachea through the nose. So the technique is often used for patients who are breathing spontaneously, but they do require advanced airway support. Now, tracheal intubation, kind of what's been labeled as the gold standard for airway control. It's considered the most reliable way to fully control the airway in these critical situations that we're talking about. Has some advantages. Provides a secure airway, so it minimizes the risk of obstruction or displacement. It also protects against aspiration, so that's one of the biggest benefits to this over any other airway, preventing the stomach contents or other substances from entering the lungs. Now, it does have some disadvantages. It requires some special equipment like a laryngoscope, a tube, suction device, all of those things that we've talked about. And as well as by bypassing that upper airway, it eliminates the body's natural physiological functions like warming up the air, humidifying it, filtering it. So, there's a few small disadvantages. However, it is what it is. So complications, you can see bleeding, hypoxia, laryngeal swelling, laryngospasm, vocal cord damage, mucosal necrosis, barotrauma. So kind of some structures and features about endotracheal tubes. So the basic structures, they have four main components. They have a proximal end, so tube, the main body. They have a cuff and a pilot balloon, the distal tip, and then the proximal end. So it comes with an adapter that connects to any ventilation device, such as a BVM or a ventilator. Includes an inflation port. It also has a pilot balloon to manage the cuff inflation. And then the distal cuff. So that's inflated using a syringe. What that does is it creates a seal in the trachea, preventing air leaks and aspiration. So the pilot balloon, that also indicates whether the distal cuff is inflated or deflated after the tube is placed. So you're able to kind of just give it a little squeeze and understand if you've still got some air into your cuff. Centimeter markings found along the tube to measure and confirm the depth of insertion, ensuring proper placement. And then the distal end. So it features a beveled tip to make the insertion easier. It does have a side opening called the Murphy's eye, which allows ventilation even if the tip has become blocked. So even if it becomes blocked with some gunk or blood or whatever, it's still able to get some oxygen to those areas that need it the most. Now, tube sizes, variety of sizes, obviously, everything from a 2 to a 10. As you can imagine, a 2 is going to be a little bitty one, and a 10 is going to be a big old throat. Length, tube varies from 12 to 32 centimeters. There are different lengths to fit different anatomies. Have cuff tubes. So from 5 to 10 typically have a distal cuff that inflates to create an airtight seal with the tracheal wall, which is essential for effective ventilation and aspiration prevention. So one of the big things is we need to make sure that we're choosing the right size for our patient. So a tube that's too small can increase airflow resistance, making ventilation harder. And then a tube that's too large can be difficult to insert, and it can cause a lot of trauma to the airway structure. So it's important that we make sure that we choose the correct tube. That's one of the reasons it's really important maybe to have a couple of tubes with you when you sit down to get ready to intubate that patient. So in the event you look in there and you see that 7 is not the right size, you can jump up to a 7.5 or an 8 or whatever it is that's what it's needed. So a stylet, that's there's a little bit of debate among whether people should use stylets or not. One way is not right, one way is not wrong. But what it does is it's a tool it used during intubation to assist in guiding the tube into the trachea. So the purpose of it's a semi-rigid wire that's inserted into the tube to help it shape it and stabilize it for easier insertion. It helps guide the tip of the ET tube over the arytenoid cartilage and through the vocal cords during intubation. So when you're preparing it, you lubricate it a little bit with a water-soluble gel, and then you bend the stylet into your curriculum talks about a gentle hockey stick curve. That's also a personal preference as well. Some people will want a bend in their tube, and some people will not want a bend in their tube. However, if you do want a little bend in your stylet just to be able to, so it will form easy with the tube. And then the stylet end should stop about at least half an inch, 1 centimeter or greater from the distal tip. Don't want any injuries coming from that. And then secure the stylet. So bend the stylet at the proximal end, so up at the top, bend it to the side to keep it from sliding further. And that stylet can do some damage if it pushes through. And then tube sizes. So pediatric tubes, 2.5 to 5 in internal diameter. It all depends upon the child's age and size. Now there is some places are kind of moving into using cuffed versus uncuffed tubes for pediatrics now. So once again, follow your local protocols. Whatever you guys are using is right. The reason that for so long we've used uncuffed tubes is because you have that funnel-shaped cricoid ring in the pediatric airway, and what happens with it is it naturally forms a seal with the ET tube, and what that does is eliminates the need for a distal cuff in most cases. Now on those tubes, you don't have a balloon cuff. They typically don't have a balloon cuff, so there's no pilot balloon to manage cuff inflation. So it's important to understand what you're using. If you're unsure of whether they're cuffed or not cuffed, you'll need to know prior to getting ready to use it. Also, the internal diameter of the nostril can approximate the diameter of the glottic opening and serve as a guide for selecting the correct ET tube size. We're not talking about if you're going to do a nasal tube, we're talking about oral. Still, you can use that diameter of the nostril as a guide. There's also, there's little tips and tricks, and you kind of within your curriculum, you see little finger or thumbnail. The diameter of the patient's little finger, their little finger, or the size of their thumbnail is another quick way just to estimate the appropriate airway size. So these are all just kind of predictions. They're estimates. So keep in mind that they may or may not provide the right size tube for you. So that's what I was mentioning before. Always have some more tubes ready. Always have 3 tubes ready, one larger, one smaller, and the one that you're thinking. Laryngoscope and blades. So the purpose of the laryngoscope and blades, that laryngoscope is essential for performing orotracheal intubation using laryngoscopy. So what it does is it allows you to visualize the vocal cords and the glottic opening. Within it, there are several components within this thing, and it has a handle, interchangeable blades. The handle houses the power source for the blade's light. Now, some are disposable, some are not. It all depends on what you're using, what your service uses, but they should all have obviously a built-in light source. There's also ones that have fiber optic, all kinds of stuff out there. So the blades, straight blade versus a curved blade. So we're talking about a Miller versus a Mac. Straight blade's a Miller, designed to lift the epiglottis directly, providing a clear view of the vocal cords. So it's often used in pediatric patients or those with an anterior airway. And then a curved blade, that fits actually into the vallecula. Remember, that's that space between the base of the tongue and the epiglottis to indirectly lift the epiglottis. And that's commonly used in adult patients. There's a lot of people, it's just what you get comfortable with. So you need to be able to use both in the event something happens and you only have one style of blade. But typically most people get kind of just start kind of using one blade as they get better at doing this skill. So how's the whole thing work? So the tip of the straight blade designed to go under the epiglottis, mention that, and directly lift it to expose the vocal cords. Now this blade's particularly helpful in infants and small children because they often have like this really kind of long and floppy epiglottis that can obscure the airway. Now be careful with adults because it's very easy to damage teeth if you're using a straight blade and not being thoughtful about the way that you're doing it. And then a curved blade. So it has some safety advantages. It's less likely to be levered against the teeth, making a safer choice for less experienced paramedics. That's why a lot of times some newer paramedics may or may not use, a Mac versus a Miller, because typically people are kind of pushed towards probably a Mac as they're newer. But the curve of the blade aligns naturally with the shape of the tongue and the pharynx. And what that does, it allows for smoother navigation during intubation. So the blade's tip rests in the vallecula. Remember, we just mentioned that. You should hopefully remember that from A and P, but that's that space between the tongue and the epiglottis. And then from this position, it indirectly lifts the epiglottis, gives you a really nice and hopefully a clear view of the vocal cords. But as I said, make sure that you have both blades, because you may need both. Now they come in different sizes, these blades, 0 to 4. Infants are 0, 1, and 2 for infants and pediatrics. And then adults are 3 and 4. Pediatric blade selection. So for children, the blade is often chosen based on their age and their height, or their height, providing a more, kind of tailored fit to them. Adults, choice depends on the clinician's experience and then the size of the patient. So if you have, a really large patient, you may need a 4 versus a 3. So just make sure that you're familiar with being able to choose the right blade and what will be needed. So oral tracheal intubation, let's talk about with direct laryngoscopy. So it involves passing that tube through that glottic opening like we've mentioned. So when do we do this? When airway control is necessary. And there's several reasons for coma, respiratory arrest, cardiac arrest. And what we're doing was providing ventilatory support in cases of impending respiratory failure, for prolonged ventilatory support in critically ill or injured patients in cases of traumatic brain injury, trying to protect that airway and maintain oxygenation. And then, of course, unresponsive patients who can't protect their own airway. So when an impending airway compromise is expected, and we're talking about burns or trauma or stuff like that, things that might obstruct the airway, that's going to be a good time too. Some precautions. Make sure you protect yourself. You got blood and saliva and all kinds of other body fluids, increasing the risk of infection or contamination. So in the event, you want to use an N95 mask or safety glasses, or a full face shield is not a bad idea. You always need to have gloves. Heck, you might even want a gown if, in the event they got a lot of stuff going on. Pre-oxygenation, we talked about that being a big point, and we're going to really kind of harp on that for a second. So why is it critical? We need to pre-oxygenate these patients with a BVM and 100% O2 to ensure that they have an oxygen reserve, not reverse, but an oxygen reserve. That's going to be essential to maintain oxygen levels during the intubation attempt. So let's talk about how we do that. So for apneic or hypoventilating patients, we want to pre-oxygenate them for 2 to 3 minutes. So during intubation, that patient's going to experience kind of some forced apnea when no breathing occurs. So the goal is to prevent that hypoxia, that we want to stay away from that during this period. So of course we want to use pulse ox and things to monitor O2 levels, aiming for 100% O2 saturation before we start our intubation. Maintain 94% hopefully during our intubation process. Now, why does it matter? Why does hypoxia matter? Even brief hypoxia can lead to serious complications, so avoiding it is crucial. Don't rely just on your pulse ox. Remember, I mentioned it in prior. There can be up to a 30-second lag on that pulse ox, so it does provide you with some really important data, but it's not, completely accurate all the time. So apneic oxygenation, we mentioned that before, and I said make sure you're unfamiliar with it. Make sure we're going to talk about that. So studies show apneic oxygenation, having a problem, it's afternoon, sorry. Providing oxygen via nasal cannula during apnea can maintain the O2 percentage above 98 for extended periods of time. There was a study that they had someone that was up to 55 minutes that they were maintaining oxygen 98% on the pulse ox when they were apneic, but it's because they had 15 liters through nasal cannula. Because of the pressure, the different pressures, it's those O2 is able to unload onto those red blood cells. So it's important that we do these procedures. So apneic oxygenation, this is just one that I built. So has some mixed reviews. Most of the studies done are kind of in an ICU setting or an ER setting, which ER is similar to us, but it's not the same. We have a much quicker duty to act, I guess you might call it. Just, we have a quicker moment that we need to do things than they do in the ICU. But the purpose is we want to denitrogenate the lungs. So we're trying to create a reservoir of O2. We want to get all that nitrogen out of those lungs so it's completely filled with O2 and they don't desat while we're doing this. Positioning is going to be important. So having their head elevated, that helps to slow desaturation. And then that improves, obviously, your view for intubation as well. You can use nasal cannulas, non-rebreathers, BVMs, all of that. You want at least 3 minutes or greater, though, of this high flow O2 to kind of try to get them their saturation up and get the nitrogen out. And I've just placed this in here so you can see just kind of an idea. When you look on our left, that's just your the normal lungs to bronchioles to alveoli. So 21% O2, 71% nitrogen. When we look over here to the right, when we've been pre-oxygenating them well, it's just filled with 100%. So what that does is just builds you kind of a safeguard to be able to slow down, take your time, and make sure that you're doing the procedure right the first time. So positioning the patient. This is a really big tip here is patient positioning. If you don't have them positioned, and what I mean by tip is it's just kind of a thing that will help you achieve first-time success rates, in my opinion, much higher than if you're not paying attention to the position. So a lot of it depends upon the axes that you see in that screen. You have the tracheal axis, the pharyngeal axis. When they're in a neutral head position, these axes are all at acute angles, which that makes laryngoscopy really hard to do as the airway isn't aligned for optimal visualization. I didn't mention it, obviously there's an oral axis too. That's what we're going to be getting into. So first thing you want to do, make sure you are aligning the axes. So you want them aligned as much as possible. That's going to make your intubation much easier. So how do you do that? Position them in the sniffing position. So neck flexed slightly forward, head extended back. What that does is helps to create more of a straight path, as well as improving your visibility of the airway structures during laryngoscopy. It's the reason that this is so important is because it just gives you a much better setup so you can see where you're going and see the structures as you pass them. So sniffing position, I mentioned that's the key to optimizing airway alignment during intubation. So how to achieve it? We mentioned elevate the occiput, so the back of the head by about 1 to 2 inches. You see in your picture there, he's got some towels. You're kind of getting that head back a little bit, elevated. Use folded towels or padding to raise the head or neck until the earlobe aligns with the sternum. Now, when you're talking about some obese patients, you may need to do something a little different. You'll ramp them up a little bit differently. Probably need to put some padding under the shoulders and the neck to achieve that proper alignment. And then if you're able to, make sure that you take kind of just a quick glance from the side. If you have the time, make sure the earlobes and the sternum are on the same horizontal plane. Blade insertion, so stand at the top of the patient's head, obviously facing their airway. And then you want to just get grip the laryngoscope in with your left hand. How you grab that, how you hold it, that's going to be different for each person, but usually kind of gripping as far down on the handle as possible for better control and leverage. However, when you see what I might call an airway master, some anesthesiologists and these different guys like that have been doing this for years, you can see them hold just with a few fingers at the base of it. So all of that's a little bit different with what's comfortable for you. So you want to open the mouth. You want to use that scissor motion that you learned in EMT school. That will help you get everything open, get the mouth open. and then insert the blade. So start by inserting the laryngoscope blade into the right side of the patient's mouth. And a big point is you want to make sure that you sweep the tongue. You want to sweep the tongue to the left as you move the blade towards the midline. What we're doing is we're trying to get trying to get the tongue out of our vision. One thing in my opinion that would help is when you're looking up like this that's going to be 12 o'clock. So when you're holding your blade up, if you'll turn it to say more 10 o'clock and then go towards that direction, that I always found that that kind of helps a little bit. It helps you to be able to see a little bit better, opens up your vision for you. And then you just slowly advance the blade into the airway while continuing to sweep the tongue to the left, keeping the airway structures in view. So you want to make sure that you gently manipulate the blade until the epiglottis is visible. Sometimes you see people get heavy-handed and everything. No reason to do that. Don't ever pry back on the laryngoscope as well. So visualization of the glottic opening. That's what we're hoping for, is when you see that picture right there. So once you identify the epiglottis, position the tip of your curved blade in the valvular space. Positioning the straight blade, for a straight blade, make sure you place the tip directly under the epiglottis to lift it out of the way. You want to be gentle with these structures. Really easy to cause some tears or some even little laceration or a scratch or something. Look for the vocal cords, because that's where we're wanting to pass our tube through. Now the bougie, we really push using the bougie here. As to when people get out in the field, they're able to do obviously as whatever you want, but this is just a safeguard to really help you get your airway the first time. But what it is, flexible device, it's got the sizes there. You see it's a 30-degree bend at the distal tip to help navigate that airway during challenging intubations. So there are reusable, there's disposable types, adult, pediatric, but is especially useful in cases where only the epiglottis is visible. So the bougie helps guide that ET tube into the trachea by acting as a placeholder. And we'll go over much more of that in lab as well. It's inserted, that bougie that's inserted into through the glottic opening under direct laryngoscopy. So you're using your laryngoscope so that you can see everything. And then you're inserting your bougie through the glottic opening, and then that helps you to guide your ET tube. So there's a couple of different ways that you can do it, but one way you can just slide the ET tube over that bougie, and it will be secured into the airway, as long as your bougie was in the airway. And then once you do that, you remove that bougie because it'll slide right out and begin ventilating. Of course, that's going to be important that you put end tidal and everything else on, looking for chest rise and fall and bilateral breath sounds and everything else that goes along with that. Now, talking about the ET tube insertion. So make sure that you have the tube in your right hand. You want to grip it near the connector, almost like you're holding a pencil. So you have a little bit of control. That way you're able to kind of twist it and turn it if you need it, or guide it in a little bit better. Introduce the tube through the right corner of the mouth and guide it through the vocal cords under direct visualization. So you want to be seeing this the entire time. Now, once you've done that and you advance the tube into the proximal end of the cuff, is positioned about 1/2 inch to 3/4 inch, 1 or 2 centimeters, past the vocal cord. So once you see the vocal cords, you pass the tube through. You want to continue on about 1/2 to 3/4 inch to secure it, and make sure that you do not insert the tube if you can't clearly see the vocal cords. Blind insertion is not a great idea most of the time. Risk misplacement into the esophagus. So one thing we don't want to do is we don't want to use the blade as a guide. So sometimes people kind of attempt to pass the ET tube down the barrel of the laryngoscope blade. There are some laryngoscope blades out there that have a really big barrel, and they think that maybe that's what that's for, and it's not. The purpose of the blade is to visualize the glottic opening, not to act as a guide for the ET tube. So there's several consequences of doing that. One is you obscure your view of the glottic opening, and then make proper placement of ET tube more difficult as well. So just, use everything properly, the way that you're trained, the way that you're taught, and you should be good to go. So then ventilation, steps after the tube placement. So we've inserted our blade, we've got them in the right position, we've done all of our things. Now and we got the tube passed. Once that cuff is passed about 1/2 inch or 3/4 of an inch beyond the vocal cords, then we're going to remove the blade. Now that's important. You need to be just as gentle taking it out as you are going in. Or let me say it differently. You may be a little heavy-handed. Make sure that you gently take out that blade while keeping the ET tube in place. Also, always firmly with your right hand, make sure that you do not let go of your tube. When I say firmly with your right hand, I mean hold on to it. Make sure you do not let go of your tube. And then remove the stylet, carefully take the stylet out of the ET tube, and we're going to start preparing for ventilation. So inflate the distal cuff. Want about 5 to 10 mils of air. Overinflating that cuff can be a problem. You get some excessive pressure that can lead to ischemia or even necrosis of the tracheal wall, so we want to make sure that we're not putting in more air. And then what can happen is someone puts in the wrong size tube and they're getting air leaks, so they just keep filling up that bulb with more and more, that distal cuff with more and more air, which can become a real problem. So after that, check your tube depth. Note the depth of the ET tube at the patient's teeth or lip. Go ahead and just write that down somewhere. Make sure that you know where the depth is. Begin your ventilations. So have someone attach a BVM to the tube and begin ventilating the patient. Now right away, go ahead and throw on capnography. Place an inline T-piece capnography monitor between the BVM and the ET tube, and we want to do that right away. And then we're looking for chest rise and fall. So during the first ventilations, observe the patient's chest rise with each breath to ensure the lungs are being ventilated effectively. So confirm your tube placement. Stethoscope to listen to both lungs and the stomach as well. Proper placement produces equal breath sounds bilaterally and a quiet stomach, so a quiet epigastrium. Be aware that in obese patients or those with a lot of gastric distension, noises, those sounds can be transmitted to the lungs, so that can complicate your assessment. Ventilation rates by your patient type, so make sure that you're ventilating properly depending upon your patient. You can see those on your screen. Apneic with a pulse, 10 times a minute, 1 breath every 6 seconds. You got an apneic infant child, 20 to 30 breaths. Patient of any age in cardiac arrest, 10 breaths. So make sure you know your rates. Of course, once again, that's a follow your local protocol thing too. And then confirmation of your tube placement. So visual confirmation, the most reliable initial method. We're just not saying it's the most reliable method, but just initial is to confirm by direct visualization of the tube passing between the vocal cords during intubation. Next step, use a stethoscope to listen for breath sounds. Unequal or absent breath sounds can tell us a couple of different things. Maybe you gutted them, maybe you put it into the esophagus rather than the trachea. Maybe you main stemmed them, so it's been advanced too far into one lung, and that's usually the right. Maybe they've got a pneumo, so air is escaping into the chest cavity. That's going to affect ventilation. And then, of course, bronchial obstruction, so blockage in one of the airways, preventing airflow to the parts of the lung. And that's going to be important just because if we've gone too deep, we're not going to be ventilating them properly. We're not giving them we're not setting them up for success. As I said, we'll say that a lot. We're not setting them up for success. So we want to make sure that we're getting equal chest rise and fall. However, if that lung's not working, then that lung's not working. You're not going to get equal chest rise and fall. Still talking about confirmation. So bilaterally absent breath sounds or gurgling over the epigastrium, that indicates the tube's in the esophagus. So you might have a bunch of vomit coming from the tube. Curriculum talks about do not remove the tube, inflate the distal cuff to block further vomit, and then turn the tube and patient to the side and ventilate with a BVM. If vomitus is not present, then remove the tube, resume ventilations with a bag mask device, re-oxygenate the patient, and prepare for another intubation attempt. Be ready to suction the airway as needed. I say that the curriculum talks, there's, you'll hear different things from different people about what you should do if you've gutted someone. Sometimes people will talk about just pulling it right away. Others will talk about inflating it. Just follow your protocol, whatever your protocol is. Curriculum basis, we know what the curriculum says. So breath sounds only on the right side. So that suggests to us that the ET tube's been advanced into the right main stem. So it's typically a quick and easy fix. So to correct it, deflate the cuff, place a stethoscope over the left side of the chest, and then while you're ventilating, slowly retract the ET tube while listening for those breath sounds on the left. Now, once you start to hear those, once those breath sounds become bilaterally equal, you should be able to stop retracting them. Note the tube depth though, because you need to know where you stopped, and so you can always check that again. Reinflate your distal cuff and then secure the tube, and then resume your ventilations and continuing monitoring. So when that tube is placed in the trachea, the bag mask device should be easy to compress. That's indicating that you have unobstructed airflow. So you should see some chest expansion with each ventilation, confirming the air is reaching the lungs. Now, if you have increased resistance during ventilation and ventilation becomes difficult, is what we're saying, it may suggest that you got some gastric distension, so air entering the stomach instead of the lungs. Esophageal intubation, tube is misplaced into the esophagus, or maybe even a tension pneumo, where that air is just trapped into the pleural space, causing increased interthoracic pressure and resistance. Hang on a second. All these words are drawing me out. So, confirmation of the tube placement. Now we'll get on to some capnography. So, combining that waveform capnography with your clinical assessment, that's really going to be the most reliable method for confirming and monitoring our ET tube placement. So as I mentioned before, you want to do your best to get that inline capnography monitor attached to the tube right away. That ensures immediate monitoring of exhaled CO2. Now, I don't know that anyone's still using the colorimetric device, but if you are, then that's what you would use. That changes color to indicate the presence of exhaled CO2. However, it lacks the continuous monitoring capability of waveform capnography. So once that air's gone through those little sheets of paper, they change, but they don't change back. And then secure the tube. So maintain control until secured. We talked about that. Never release your grip on that ET tube. That's going to be really important until it's been properly secured with a commercial device. So even after securing, support the tube manually while ventilating to prevent that displacement that can be caused by sudden movement or even jolts from the ventilation device. So use a commercial securing device. Lots of them out there, just different tube tamers, and make sure you get one of those on there. You don't have to, if in the event you don't have one on your truck, in the event your service doesn't carry them or whatever, tape works really well. That's what we've used for years in the past, and tape works really well. But you need to make sure you do a good job of it. Don't just tape it down to their cheeks. You need to go all the way around. And then note for tube depth. So record that centimeter marking on the ET tube at the level of the patient's upper teeth to ensure proper placement is maintained. So make sure that you're marking it so you know where you're at. Disconnect ventilation, temporarily remove the ventilation device to avoid interference while securing the tube. We're still talking about securing the tube. Center the tube, adjust it so it's positioned in the center of their mouth for stability and comfort, and then secure the tube. So with that commercial securing device, place it over, tighten the screws down, however your thing works, and then reconfirm placement again. So, auscultate breath sounds, looking at capnography, all the things. Now, some of them have bite blocks. Most commercial devices have some type of bite block, so patients aren't able to bite down on that and kind of obstruct the flow. But whether it does or doesn't, just be aware that if it is, when you're attaching it, there may be something you need to pay attention to while you're putting it on their face and in their mouth. Now, video laryngoscopy. So that enhances your ability to visualize the glottic opening and vocal cords. They're becoming quite a bit more popular now out in the field. So what it does is it makes it especially helpful in some pretty challenging airway scenarios. So you've got a video monitor, kind of displays a live view of the airway, and you're able to see everything in a nice big clear picture. However, in my experience, it does kind of demand a little bit better hand-eye coordination than just using your normal direct laryngoscopy. So, but just be, like I keep saying, make sure you're familiar with it. There's a lot of different ones. You know, you've got them with a built-in monitor, separate video monitor, depending on what you may or may not have. And then going on down, single-use blades as to whether they're with video laryngoscopy or whatever. These are just a couple of different models that you may see. Now, tongue displacement. So some video laryngoscopes require you to displace the tongue to one side to create a clear view of those airway structures. So some models are designed for a right midline in the mouth and just following the curvature of the tongue. Just depends, like I said, it just kind of depends on what you have. Now the thing is, always have a backup option, as we talked about before with your tubes. In the event that this thing fails or it runs out of batteries or whatever, you may need to go back to just kind of your old school intubation. Nasotracheal, that involves passing a tube into the trachea through the nose. So typically without direct visualization of the vocal cords. Now when it's used, particularly useful for establishing an airway when performing laryngoscopy is difficult or risky. So some kind of indications best suited for spontaneously breathing patients who need a definitive airway. So responsive patients, with altered mental status and intact gag reflex. So we're thinking kind of COPD, asthma, pulmonary edema, what we talked about with CPAP, some of those patients. Contraindications. Apnea. These patients require orotracheal instead. Remember, for nasal tracheal intubation, you need them to be breathing, and when you hear them exhale, you'll know that you can pass the tube. So if they're apneic, you are not going to have any breath going in and out, and that's going to make it really hard for you. Head and trauma mid-face fractures, not going to be a good idea. Anatomic abnormalities as well. And they can definitely have some bleeding going on. So if there's a lot of blood clotting disorders or they're on anticoagulants, that may be something to be just cautious about. And it is what it is. If that's what they need, then that, and you don't have RSI or something, then that may just be what it is. But now there's some advantages. With every advantage, you have some disadvantages. So let's talk about those. So the advantages can be performed on a responsive breathing patient, which makes it suitable for those with intact gag reflexes. It doesn't require a laryngoscope. In my opinion, it requires a little luck though, and sometimes you don't get that. But the mouth does not need to be opened, making it ideal for patients with limited jaw mobility, and it doesn't require putting a patient in a sniffing position, so it makes it safer for patients with maybe possible spinal injuries as well. But since it's inserted through the nose, the patient cannot bite the tube, so that also helps, and then it's often easier to secure. Now, disadvantages. It is a blind technique. That's where the luck comes in. I feel like good positioning, that neutral position, and a little bit of luck, and maybe you can get it. So it's a blind procedure. So typical tube conformation methods, direct visualization, you're not going to be able to use. So it's kind of some extra diligence to confirm proper tube placement using auscultation, capnography, other techniques. And then some complications. So bleeding is always, not always, but it's a common complication because that nasal mucosa is highly vascular. So reducing your bleeding risk, gentle insertion technique, water-soluble gel. Also, if in the event that you have an anesthetic lubricant with some vasoconstrictive agent, so like a lidocaine with epi or something like that. I can't think of what it's called, like that. Phenylephrine, I think, is on a lot of trucks. That helps to just shut down those vessels, and that will hopefully help to decrease some bleeding. Now, your equipment, you're going to need a lot of the same equipment. However, you're not going to need a laryngoscope. So make sure, one big part about this, make sure that you select an ET tube. It's slightly smaller than the patient's nostril. That's going to help you with smoother insertion. There are some specialized ET tubes out there. endotracheal tube that can help you as well. Flexibility, more flexible than standard ET tubes, making it easier to navigate through the nasal passages. And it also has this weird little trigger feature that kind of moves the tube anteriorly, so it increases the curvature of the tube and it helps guide it. So the technique, and when we're talking about this nasotracheal intubation, remember they need spontaneous respirations. I think I said exhale. As they inhale, I think I said exhale earlier, but as they inhale, that will allow them to help us properly perform this procedure. That allows us to properly place that tube. So you're going to want them breathing normally. You're going to be listening for when they're doing that. You can kind of start to get your tube in there and listen. You can even listen through the tube, or there is a little device, I can't remember what they're called, but it's a whistle tip, I think. And when it made a little whistle noise, you knew that you were good to go. So after preparing your equipment, pre-oxygenate your patient, insert the tube into their nostril. Use the right nostril by default. If it's blocked, then you can use the left. Rotate the tube 180 degrees as the tip enters the nasopharynx to align it properly, and then aim the tip of the tube straight back toward the ear, not upward, toward the eye. So that prevents trauma and guides the tube into the correct pathway. So you want a positioning above the glottic opening. Place the tube just above the glottic opening. Allow the patient to draw the tube into the trachea during a deep inhalation. I think I'm saying everything. Exhalation, inhalation. I apologize. Like I said earlier, it's in the afternoon and I'm misspeaking, so that's just not abnormal. And then manipulate the head for tube positioning. Adjust the patient's head position as needed to control the tip of the tube, and then just ensure that it aligns properly with the airway. So what that does is that helps maximize that air movement through the lungs during insertion. Timing with that inhalation, instruct the patient to take a big deep breath. As they inhale, gently advance the tube into the trachea. Remember, because of the epiglottis and everything the way it works, as they're breathing, then we open up the trachea and we shut down the esophagus. So that should give you a much cleaner shot and the correct kind of anatomy and physiology to be able to do this procedure. So once you have an increase in air movement through the tube, as you've pushed it through, we should be good to go, hopefully. Now, identifying and correcting some misplacements here. So soft tissue bulge. If a soft tissue bulge appears on either side of the airway during insertion, the tube may have entered the piriform fossa, which is a structure near the airway. So hold their head steady, slightly withdraw the tube, detect the maximum airflow, then advance the tube on inhalation to ensure proper tracheal placement. So no soft tissue bulge, esophageal placement. If no bulge is observed, the tube has likely entered the esophagus. So withdraw the tube until you detect airflow, because we're talking about there's no airflow. Once the airflow is confirmed, then you can just extend their head to help guide the tube into the trachea. And then finalizing our tube placement. So inflate the cuff, inflate the distal cuff with a minimum amount of air necessary to create an airtight seal. You don't want excessive pressure again. Ventilate them to the tube and begin ventilating to ensure proper oxygen delivery. Confirm and monitor placement. So confirmation and ongoing monitoring of the tube's placement are critical to ensure effective ventilation and avoid complications. And then secure it, get everything kind of cleaned up, use some tape. You may have a commercial securing device to help with that as well. Make sure you document your tube depth, so record that. Now with this in your textbook, you notice on there it says 1611 for performing nasotracheal intubation. All of these skills all have, I think they're called skill drills. And then face-to-face. So this is kind of an interesting and unique one, but face-to-face intubation is at the paramedics. At the paramedic's face is at the same level as the patient's face. So typically, when standard positions aren't possible, such as in a confined space or with certain injuries, this would be a time that you might do that. So this Technique is similar to oral tracheal intubation using direct laryngoscopy with some key differences. So head stabilization is going to be a big thing. Second paramedic throughout the procedure would be wanting to, hopefully would be able to stabilize him. Unlike typical intubation, the head is not in the sniffing position. So let's talk about the laryngoscope, tube positioning. Laryngoscope, typically with a curved blade, is held in the right hand with the blade facing downward, so kind of almost like a tomahawk. So the ET tube is held in the left hand, opposite to the usual configuration in the standard intubation. And then once the blade's in position, the intubator can make minor adjustments by pulling the mandible forward or pressing down also to help visualize that glottic opening. So in the event you're in a really kind of challenging situation here and your normal intubation is not going to work, this is one that will work for you. And a failed intubation. So what is that? It's an intubation attempt that is considered failed when our adequate ventilation and oxygenation cannot be maintained, regardless of the airway management technique that is attempted. So if an airway can't be secured, consider performing a surgical airway. So, talking about a cryoc or something like that, following your local protocols, of course. But you need to be able to address a failed airway because it happens. It's critical to prevent hypoxia, make sure that we have hopefully a patent airway for that. So needing to have a backup plan is really going to be important. Tracheobronchial suctioning. This doesn't just happen for everybody. What this is for, it involves passing a suction catheter through the tube to remove pulmonary secretions. So we're only going to do this when absolutely necessary. One thing is, like, you can think about like a CHF patient or somebody that's just full. There's someone that you could do this to if you weren't using CPAP. So unless it's just required, don't just use this, typically. That's a strict sterile technique. Remember, you're advancing something directly into their lungs when you're doing this. So suctioning also, if you think about it, you're suctioning fluids, you're suctioning oxygen, all kinds of stuff. It can lead to cardiac dysrhythmias, even cardiac arrest, for a couple of reasons. Hypoxia as well as vagal stimulation, you can really vagal them down and cause some problems. So just be thoughtful when you're doing this. Make sure your timing is good. Make sure they actually need it. So if they have massive secretions when we're talking about this tube and we can hear things and all of that, that's who is going to be indicated for this. Before suctioning, we want to make sure that we oxygenate them well. We want to pre-oxygenate them. In the event that, we're talking about someone that's been intubated, and in the event that secretions are just super thick, so that's, just pretty gross, you inject, 3 to 5 mils of sterile water in the tube to help loosen them, because we've got to get those things out. So insert the suction catheter until you meet resistance, and then apply suction only while extracting the catheter, and do not exceed 10 seconds. And then you resume ventilations. So reattach your BVM, continue ventilations, reassess for oxygenation, ventilation, maybe hemodynamic stability, lots of that stuff. So obviously there's a skill drill for that as well. And then field extubation. So what is extubation? Well, intubation was when we introduced that tube into their trachea and was breathing for them, and extubation would be when it exits. So extubation is that process of removing that tube from an intubated patient. It's rarely performed in pre-hospital settings unless it's absolutely necessary. So when might you consider it? If they're intolerant of the ET tube to the point that it cannot be managed otherwise, it would be much better to sedate your patient to manage their discomfort rather than removing the tube. In my opinion, you should probably always contact medical control for this. Even if you have a protocol that says you can do it, I would still probably contact medical control, because the risk of that, one of the biggest risks is overestimating the patient's ability to protect their airway. And what that can do is just lead to potential airway compromise. You also have a high risk of laryngospasm. So extubation in responsive patients carries a significant risk of laryngospasm, which can obstruct the airway. There's airway swelling. It's just not unless you're just certain, extubating in the field is not really a great idea. Like I said, what's a much better idea would be to sedate your patient. Use a benzo and get them calmed down and talk them through it. Lots of risks involved. So contraindications. Absolutely contraindicated if there's any risk of recurrent respiratory failure, if there's uncertainty about their ability to maintain their airway spontaneously. If you've been around a while, you've probably seen someone that was on a full arrest and halfway through the code they started coming back. Well, that's someone that could certainly fight the tube and all of that. However, once again, because of the trauma that we've done by inserting that tube and the pressures that we've put in them, it's probably a much better idea, again, I just keep saying it, but just to sedate them. So if in the event that you are going to, or you are thinking about do it, discuss the procedure, make sure they're prepared and cooperative, positioning the patient. So you want to have them, sit up or lean slightly forward. You need to be prepared for emergencies, though. You need to have your airway ready to re-intubate. You need to have some ventilation system put together. You have suction ready. So, like I said, I sorry to keep going over it, but I just don't think it's a great idea to extubate somebody like that. So confirm airway protection. So before proceeding, verify that the patient can protect their own airway, including handling secretions, maintaining spontaneous breathing. Suction the oropharynx to clear the secretions and reduce aspiration risk. Deflate the cuff. As the patient begins to exhale, deflate the ET tube's distal cuff. That helps to prevent some accumulated secretions from being aspirated into the lungs. Remove the tube during the next exhalation. One steady motion, so out it goes really fast. You'll probably see this while you're doing some clinicals in the ER or wherever. You might see someone get extubated. Sometimes they tell people to cough. That will help get that tube out as well. Now, with this, think about it. As you're pulling something out, it's really easy to kind of engage someone's gag reflex, so prepare for vomiting. Another reason to not do it in an ambulance. So place a towel or an emesis basin in front of their mouth in case they vomit. And the way my career has been, in case means they probably will. Okay, I apologize about the couple little weird things. I'm not sure why everything went dark on us, but it only lasted for a little bit, and then we had a few little misspeaks, and get used to that. I'll be honest with you, that's not anything completely uncommon. So, as always, have a good day, and we'll see you next time. We've got the next one coming up.